Short stem in DDH patients, I think it's easy. Where it fits, it fits. Where it doesn't, it doesn't. So it's like with all the other stems. We already heard in the very excellent presentation by Luigi Zagra what are the problems we are dealing with in DDH. So we have, you know, a crow or what a Hartov-Filiakis classification doesn't really help when you have to deal with those patients, especially those patients with many operations before. You will have the problem that you deal with, for example, stiff hips, and they are much more difficult than a high dislocation that is high riding, but is not stiff because your musculature has an adequate length. Other examples you can see here you have to deal with. What I would like to share with you is how is our approach, and it's a little bit different than I've heard today. We are still using trochanteric osteotomy. So this is a patient of 28 years. She had 4 surgeries before, and you see it's a dysplastic hip, a completely deformed femoral head, and you see she had already trochanteric osteotomy. What is the main point we have to deal with? It's planning. Planning, you have to plan to know what you have to deal with. You have the normal X-rays. We often perform CT scan to know what is really your bone stock. We need MRIs in some cases to know, especially when there was previous surgery, to know what is the musculature about. And we have orthoradiograms because it can be very misleading, as we heard this morning, that you think your legs are equal, but there is quite a high difference and you have the risk to overlength the leg. So it will also help you to decide on your approach. So our technique today for difficult hips, not for the simple ones. In the simple ones, we typically use the anterolateral approach. We do still a trochanteric osteotomy. And the trochanteric osteotomy done with a step is different to all those osteotomies described in the early days by Charnley and so on. They had quite a high problem of fixation. We saw this in the nice operation by Klaus Siebenrock yesterday, how we perform the osteotomy. We do a proximal starting and ending at the same, like straight osteotomy, but we tend with the proximal one 3 millimeters higher than with the distal one, so the lateral side, and the distal one goes 3 millimeters more to the medial side. If you do a total hip, you can even make your step quite bigger, and when you use then a chisel, you will have a nice step that allows you to have a good fixation, stable fixation, good orientation, and if it's needed, you can do proximalization in addition, but you can also do a distalization. If you take out bone from the trochanteric area, you can add it, and then you will have a distalization of the trochanter. So that's our approach. Then we do the the neck osteotomy when we have dislocated the hip. And then we are looking for the center of rotation. And this is relatively simple. You go to the teardrop figure, to the original teardrop figure you find in almost all the cases with DDH, and then you ream in relation to the teardrop figure using it as a landmark. You do your first some reaming steps in order to know how is the deficiency, how big is the deficiency, how we can deal with the deficiency. And then you know how much deficit you have, bony deficit, and you can use the femoral head as an autologous graft, and you put it in a bigger piece than you would that fills the defect, so the defect should be overstuffed, and then you can do the reaming up to the size you had before, and then you can fix your, or you already did fix your autograft with 2 Kirschner wires or even with 2 screws. At the beginning, you can do it after the reaming, the definitive fixation with 2 screws. We usually use 3.5 5 millimeter screws. And this is what we achieved in this patient. And this is 6 years down the road. So you have an autograft that is completely healed in, and you have plus minus a primary hip, as you would look for in a primary fixation. These are cases, they are much more difficult just to dealing with the leg lengths. In earlier days, we have used cemented ones, and we did the shortening, especially in the metaphyseal area, to get the shortening. These are, as I already said, cemented ones, and we distalize the trochanters on both sides. This is a very difficult case, as you can see, with this very high riding trochanter. Those are definitively not situations in which you can use a short stem, because you have just a very small diaphysis that will not allow to use a short or whatever conservative stem. This has been done also with the osteotomies, and you see the center of rotation is at the right place and the trochanter is brought down. This is a very difficult situation in which you have to do an osteotomy, and it will also not be a case you will use a short stem. This is with shortening in the metaphyseal area. As I already said, this is a case very difficult because it's a completely stiff hip for many, many years, because she has been operated before on both sides. And what you can do in those cases, you will have to find a compromise with still some kind of high riding trochanter, because the musculature, which is usually quite long in high riding in high riding DDH, is in a stiff hip not long, and you have almost just scar, and it will not help you to bring the trochanter down, because you will destroy the whole musculature in the trochanteric area, so the abductors. This is much easier. In this case, we did also a trochanteric osteotomy, but it was also not a case for a short stem, because the area of the calcar is almost completely missing, so you need a conical stem to adapt for the high antetorsion and for the missing calcar region. In these cases, you have almost a normal proximal femur. It's easy to use a short stem, as you can see here, 6 years and 5 years down the road. You have the same augmentation in the acetabular part, and bone that looks like the native bone 6 years down the road. Very similar in this situation, augmentation of the acetabular part, but here we had to bring down the trochanter because in the former operation it was almost 90 degrees to the normal direction of the insertion of the gluteus medius. Also, a case that is now 5 years down the road. Sometimes you have to adapt for antetorsion, retrotorsion, and in these cases it may be helpful to have a short stem which allows you to have rotational possibilities for adaptation, because it's not over defined, especially in the posterior direction, so you can do the adaptation. This is also a case 10 years down the road. It looks also nicely, as I would think. Short stem, you could also have used a normal stem. So that is not really the question, normal, short. It's more a question how the prosthesis will fit into the proximal femur. That is a situation after PAO. Once again, the proximal femur is distorted, and in this case, there was a distalization of the trochanter you have to take in account. So post-op, during the operation, we did a proximalization of the trochanter, as you can see here, in order to have a better relation to the center of rotation, and this is 10 years down the road with a short stem. It could also have been used a normal stem like a CLS or whatever. Similar here, in this case, probably we shouldn't have We could have done also a conical stem because it's a quite difficult situation on the left side. And you see we had to quite difficulty to adapt the prosthesis to the proximal femur. So this one is in a valgus position, which may be not ideal, even it is absolutely stable and the patient pain-free. In some cases, you can do also an anterolateral approach, as in this one, when you do the planning and you know you don't have to do a real big augmentation in a very long neck. As you can see, the prosthesis is relatively high riding, but center of rotation and leg length are restored completely. A last case, 42 years old. As you see, once again, you have a high riding head, you have a dysplastic hip, and you can solve this with the technique we showed you. And in those cases, with almost a normal proximal femur, you can easily use a short stem or a conventional stem as you would like. When is a short stem an option? I think the most important thing is that you do a decent planning that tells you you can use it or not, and if you are not sure, you should have 2 systems in your OR ready to deal with the situation you find intraoperatively. You need a more or less normally shaped proximal femur to use a conventional or a short stem. You should have no risk for over-lengthening the leg, otherwise you have to use another stem in order to be able to shorten your femur, and you have to be able to correct the rotation as it is necessary. Thank you for your attention.